So all these things are possible. All right. Now we will get to that period in between the removal of that necrotic patch and this granulation tissue. What we had to do to ensure that this granulation tissue comes out. Please, next slide. All right. Tissue management. Now, infection control. How do we know that a chronic wound is infected? Okay, how do we know that it's infected? Now, this is an acronym, the nets and stones. The nets and stone is a way of knowing whether the wound is infected or not. Now, once a wound is not healing, it's most likely infected. If it's not healing, it's most likely infected. If it's really exudating, a lot of fluids or discharges are coming from it, particularly if it is colored. If it's not colored, it can also be. But if a large volume of fluid is coming, if a small volume of colored fluid is coming, then it's most likely infected. Now, a wound might have a good granulation tissue, but bleeds readily on opening. We should suspect infection, except if there is a traumatic removal or whatever gauze that we have on it. So if you are not patient about opening a wound, it could also bleed. But if you are sure that you are very careful in opening it, but it bleeds readily, that wound is infected. Now you could have the debris, which is what we talked about earlier. Most likely the presence of necrotic tissue or slough may suggest that that wound is infected. Smell. I will agree. You will agree with me that you must have seen patients with chronic wound that smells a lot. Those are signs of infection. Now these other ones too may also tell. The satellite area was what I showed earlier. That satellite area that I showed earlier, that small wound around the wound suggests that that wound is infected. Okay. Now next slide. All right. So this is a image of patient who has their wound infected. If you look at the dressing that was removed there, a little bit of yellowish tinge, all right, and then some discharge at the corner of the leg. Now if you look at this other wound, you look at the granulation tissue, apart from the white stuff that are there, is also cobblestone. This is suggesting an infection. If this is what I was describing earlier, this hyperpigmentation around the wound. Once I see this, for example, now I know this wound is infected. I know this wound will have a venous insufficiency as a background problem and most likely the reason for chronicity. And then definitely I know what to do subsequently. So how do we treat infection? Next slide. How do we treat infection? Okay, before that, I use this slide to show, okay, even though this is what we want the granulation tissue to look like, but by the time you open a wound and it's really bleeding, we should suspect that it may be infection. That is after ruling out that I actually took some time to open the wound. And then that other one shows cobblestone appearance as well. Next slide. How do we treat? Now, the treatment of infection in chronic usually should be local. Okay, it should be local. Most of the time we treat those infections in a systemic way. Now, we only encourage a systemic treatment of chronic wound if there is evidence of deep infection. So that means there are deeper infections, then you need to use systemic infection. Or you have tried to treat locally, is not working. Well, maybe you can introduce systemic antibiotics as well. But that local way is the best way, an ideal way of treating a chronic infection. So what do we do? Those images that we have seen, some have granulation, necrotic tissue there. What do? You remove it. Remove the necrotic tissue. Ensure that the wounds are clean. So you can use some cleansing agents to clean while we are doing dressing. And cleansing agents as common as normal saline can be used. There are other cleansing agents, more advanced cleansing agents that are available. I'll show some images there. and then use topical antimicrobial agents. What are the common topical antimicrobial agents that we have? Povidone, um, povidone iodine. A 10% povidone iodine is readily available. It's a very good antimicrobial agent. Then honey too has some subtle antimicrobial property, so that can also be used to treat infection. Other ones, if you have access to it, are the silver-based dressing agent. The Exalt, the Damazine is also an antimicrobial agent. Okay, Acticoat and all the rest. All those ones can also be used. But the Cutimed Sulfact also can be used. Now, next slide. Next slide shows some of those agents that I talked about. These first two bottles are the cleansing agents that we can also use apart from normal saline. But normal saline or sterile water would do just equally the same work. Okay, and then these other ones are the topical antimicrobial agent that may be available. Now, moisture balance. I remember when we were growing, one of when it comes to the issue of wound, is summation. Okay, the wound should have some level of moisture to allow granulation tissue formation and reepithelialization to occur. If it's entirely dry, it is not good for the wound. If the edges of the wound are dry, it is not good for the wound. So we should allow some level of moisture balance. Okay, at the same time, the discharge from the wound should not be too much and it should be well controlled. Next slide. So if it is too dry, what do? We can use, like this image that we have now, is a wound exposing the bone, and then if you look at the surrounding too, is also a little bit dry. Now this kind of wound, what do we dress with? Get a saline soak gauze and dress with that wound. Please don't use honey, don't use povidone iodine, just use something that can create moisture within the wound. Other things that can create moisture: hydrogel, hydrocolloid. This can also bring some fluid into the wound and then can moisturize. Now there are situations where the wound is not completely dry, but you need to provide some moisture within the bone, within the wound. And these are situations where vital structures are exposed. You don't want them to get dry. So this is an example. The bone is exposed here. It may be the tendon. It may be that there is one vessel somewhere that is actually out, that once it gets dry, desiccated, that's the end of that structure. So if you want to provide some moisture for those structures, then you can also go this way. All right, but where next slide, when there is too much of discharge from a wound, then that needs to be well controlled. The wound should be moisturized, but the surrounding skin must be dry. The surrounding skin must be dry. Now this is an image of a wound that is really discharging. So you can see the level, the layers of gauzes that was used. Even with this one, up to the external level, all were soaked. All right, so if you have wounds that you think the discharge is much, you don't use gauze alone and crepe bandage. No, we need to increase the volume of something that can receive what is coming out from that wound. And this is where you put the issue of Gamgee. Now Gamgee is not something I see commonly that people use, but I think I will encourage us to always use it, particularly when you have wounds that are discharging. So put some layers of gauze and then put Gamgee over the wound, so that whatever that is coming will be, the Gamgee will receive it and prevent the skin around the wound to get soaked. Now the other things that can be used, this is a foam dressing. It's actually built to absorb discharges from the wound, and this is a machine called a vac machine. Vac machine is a negative pressure therapy kind of thing, that once you apply it, next slide, once you apply it to a wound, for example a discharging wound, it sucks out through the tube into that machine. All right, so you can leave this kind of dressing for like 1 week, and then it continues to bring out the fluid into that machine. All right, but where all these ones are not available, Gamgee will do the work. How do you make gamji? All right, gamji is very simple to make. You just lay a gauze on the table, for example. Put like two layers of cotton wool roll. We have this cotton wool roll that they sell. Just roll it over it, like two level of it. Put another gauze over it, and that's all. Then you can sterilize that for use. Now the sizes, depending on the size of the wound, you can determine the size of what we want to use. Now the edge advancement. Now usually you don't do so much about the edge, only that you monitor it. Once these first three things have been taken care of, that's the tissue management, the infection control, and the moisture balance, the edge will certainly, you know, continue to advance. So they will continue to do well. All right. So in some situation, people have decided to prescribe some growth factor to encourage healing from the edges. The growth factor is actually very expensive and is not readily available. So the next slide, please. Now this slide shows a wound, and that one shows we can see the edge of that wound there. It's actually fibrotic and dry. Now if you have that wound, it's not likely that wound will heal. Not likely. But what I did there was to debride it initially and then continue with a dressing that can provide moisture, which is an hydrocolloid. And this is what we have some weeks afterwards. It's almost certain that this wound will heal in no time. Please, next slide. Okay, so this is another image showing how an edge can advance. All right, we'll see the size there, and then we'll see the size there. Please go back to that other one. If you look at the lower corner of the image on the left, so you will see that satellite lesion again, telling that that wound was infected, moisture imbalance is there, and then once this is done, so we'll see the progress of the wound weeks after. Next one. So something similar here. And then what is this one telling us, please? What sign is that one? Hyperpigmentation, venous insufficiency. Please move on. Now, venous insufficiency may be in isolation, may also follow a long-standing, just normal wound. So, a post-traumatic wound, for example, now that have been poorly managed over a long time, may then develop some venous problem. So it may not be the primary problem, but as a secondary problem to that initial problem again. So this is actually very common in patients who have HBSS. They have wounds that are not related to venous problem initially, but because it's been long-standing, some veins around their legs then continue to have some issues, and then they have that in addition to the background problem that they have. So like I said earlier, wound may have multiple problems and we should be able to recognize it. Once you recognize that, then you will be able to solve it. Now this is a patient, if you notice that first image, has some slough over the wound. Okay, dressing was started. The patient is an HBSS patient and some has some venous problem, insufficiency alongside with it. How do you manage venous insufficiency? All you need to do is encourage venous drainage. Usually they present with edema. They have some subtle edema in the leg. So you want to reduce that edema. You can manage that by elevation, simply elevation. But most of our patients will not adhere to those instructions. If you tell them to elevate the leg now, they do it 1 or 2 hours in a day. They come back to you, they say they have been elevating it the whole day. Or some of them will actually be righteous. They will elevate it for most time of the day, and then for 1 or 2 hours in a day again, they are roaming around the whole country. So what they have gained over the day, they will lose it within that short period because fluid will go back. Will go back to where it's coming from. So another thing that we can do is use this compression bandage. We call it Kuban. So Kuban is a compression bandage that ensures that there is a rigidity outside the skin, so that even when a patient moves around, okay, what the muscles of the leg will do is continue to pump against that rigidity, and the benefit of that is that the wound, the fluid continues, the venous drainage continues to go up. All right, it continues to go up. Next slide. So we can see the results some weeks after. That's the initial one, and then this is about 2 or 3 weeks after. There's some improvement. Now, pharmacological agents. Now, modulation. Before I go to pharmacological agents, I must say again or re-emphasize that modulation of wounds, it takes some skill, but by the time we continue to practice this principle, we then continue to improve on those skills. Now, like I said, you may not need to treat one particular problem. You may need to combine those problems. Okay, there are situations where a patient has some slough, patient has infection on the wound, and patient has discharges. So it has all these three problems. What agent do we prescribe? How do we manage such problem? So if patient has some infection, I would like to prescribe an agent that will take care of that infection. Discharge is high. I will need to add something that will absorb the fluid for me. Maybe there are necrotic tissue in the wound too. I may need to add something that will debride. There may be some agents that combines treating infection and debriding at the same time. Okay, so that agent could be like honey. Patient have some necrotic tissue here and there. I think this wound also has infection and is also discharging. So I prescribe, rather than use treat of infection alone with a povidone iodine, I can decide to go honey. Honey will give me a debriding agent, will also give an antimicrobial agent. Now, most of these new dressing agents, they have that mindset already. So we have a lot of dressing agent that combines multiple of these things. So that once you have multiple problems, you just use one single agent that can take care of those things. So there's a foam dressing I showed earlier. That foam dressing is just a foam, it looks like a foam dressing, but it also has some antimicrobial agent impregnated in it, usually silver. So as they are absorbing the fluid, which is managing the moisture imbalance, they are also releasing some antimicrobial into the agent, into the wound, taking care of the infection. Okay, so in this our environment, if we don't have all those ones, the ones that we have, we should be able to manipulate it. But I must tell you, povidone iodine, honey dressing, gamgee will sort out a lot of problems. Povidone iodine, honey, and gamgee will sort out a lot of problems. Forget this advanced dressing agent. If you have access to it, let us use it. But if you don't have it, those three things will take care of a lot of things. But identify the problem, try to sort it out. Now, pharmacological agent, for me, I really I don't, except if there is a systemic issue that needs treatment. So if a patient is diabetic, for example, now, so of course, it requires some systemic treatment. Insulin or OHA can be prescribed. All right, so those are specific things. Now, venous insufficiency too, there is Daflon that can also be used. All right, but generally speaking, we've talked about the use of systemic antibiotics. We may use it, we may not use it, but generally is not encouraged except if there is a deep infection because of the possible resistance that may come from it. Topical antibiotics will do the same job. So we can place our patients on vitamins. Somebody has presented some immunovitamins that can also be used. All those ones are also going to help in healing. Now, to conclude, next slide, please. I want to say that for us, caregiver, we need to pay great attention to signs and details that the patient will be showing us, and then the wound will be showing us. Not likely they will be able to say it, but they are there for us to see and to interpret rightly. There is also room for modulation of dressings agents. Now, another thing to emphasize again is that the wound is dynamic. So it is not I prescribe honey today, and that is what patient will continue until the wound heals. That may happen, but tomorrow we may need to change the dressing to another thing, because the wound may have improved from having some necrotic tissue, and then the necrotic tissue have disappeared now. So we need to use something else. Or the wound has actually gone bad. Initially it was discharging so much, but now it's discharging. Then I need to change my game. So please don't let us be fixated on this dressing agent, particularly if it is working. That working may change the wound to another stage. So please recognize that this wound has changed to another stage, which may be a progress in the wound. So you then need to change also. I must tell that wound care may take time. It is costly to the patient, but most of the time is rewarding. Thank you for your attention.
Thank you very much. Please, another round of applause for our guest lecturer.